mission. And our mission is improving healthcare equity, access, and outcomes for the people we serve while saving Coloradans money on healthcare and driving value for Colorado. Next slide. The Department of Healthcare and Policy and Financing specifically administers the Health First Colorado, which is Colorado's Medicaid program, the Child Health Plan Plus, or CHP Plus, and our healthcare programs for Coloradans who qualify. Next slide. Today's training, our target audience is for home health agencies that are providing or thinking about providing private duty nursing. The goal for our training today is basically a high-level overview of the private duty nursing benefit. We'll review the PDN regulations, outline the program details, and also touch on the billing manual. Next slide. So the overview of PDN services, the current definition and rule language, which directly matches the federal statute, is that private duty nursing means medically necessary nursing services that are more individual and more continuous care than is available under the home health benefit or routinely provided by the nursing staff of a hospital or skilled nursing facility that allows a member to remain in their home or community-based setting. The purpose of PDN is to support members with complex medical needs, enabling them to remain in their homes and communities while receiving the necessary nursing care. Next slide. Benefits for adult members under private duty nursing is that there's more comprehensive care. There's access to continuous skilled nursing services that are tailored to the individual to meet their complex health needs. There's the independence that supports them living at home, maintaining community ties, enhancing their quality of life. And it's cost effective. It reduces the need for prolonged institutional care or facility, inpatient facility, and leads to potential cost savings for the state. Next slide. Benefits for pediatric members is that it's more family-centered care, and it enables children to receive the necessary medical care in their familiar home environment. There's developmental support to support that continued growth and development, and that continuity of care, again, with a consistent monitoring and management of their chronic conditions. Next slide. So PDN is one of the more intensive levels of care in the continuum of care options that are available in the home and community-based service options that we have here in Colorado. So you can see that this is not an all-inclusive list. This is just examples of some other care options, going from a minimal level of support all the way to the intensive support. And a combination of care can be utilized from different areas in order to meet the member needs, and should be explored prior to utilizing this more intensive level of care under private duty nursing. Next slide, please. So eligibility criteria. There are no age restrictions for private duty nursing. Pediatrics, any age adults can receive the private duty nursing. The member must be eligible to receive state plan benefits. This can be used in conjunction with waiver services as long as there's no duplication of services being provided. A member must be able to be safely served in their home or community-based setting under the agency limitations of PDN benefit and the staff that is available. A member cannot be residing in a nursing facility or hospital at the time of PDN services. And we must have an approved prior authorization for medical necessity as defined in the program integrity, as well as STT for children and youth. Next slide. So dividing out the eligibility criteria between adults and pediatrics. So for adult members age 21 years and older who demonstrate medical necessity for the skilled nursing services, which is defined in the program integrity section of the Colorado Code of Regulations, which is listed there, are technology dependent and for whom a delayed and skilled nurse level interventions would result in deterioration of a chronic condition, loss of function, imminent risk of health status due to medical fragility, or risk of death. Those all must be met in order to meet the eligibility for private duty nursing for an adult. Adults may be approved up to 23 hours per day. Next slide. So for our pediatric members, our children and youth members age 20 and younger who demonstrate medical necessity in accordance with EPSTT, which is our early and periodic screening, diagnosis, and treatment program. And there's the link to the section that you can reference of the Colorado Code of Regulations. The pediatric member must require skilled nursing assessments, intervention, and evaluation of both equipment, if there is equipment applicable, and the member. The services provided shall be medical in nature, safe, effective, generally recognized as accepted method of treatment, not experimental or investigational, cost-effective, and necessary for the member's condition and within accepted standards of nursing practice. And that directly meets the EPSTT clarification. Pediatric members may be approved up to 24 hours per day. Next slide. Covered services. It's really simple. Skilled nursing is covered service. It's continuous face-to-face care provided at the RN, registered nurse, or a licensed practical nurse, LPN, for individuals with complex medical needs. There is a provision in PDN services that group nursing care can be provided to more than one member simultaneously in the same home or the same setting. Next slide. Benefit limitations. Services that are not authorized for PDN. Care that is non-skilled are considered ADLs, or activities of daily living. If the plan of care does not identify any skilled need or skilled care need, observation and monitoring not requiring any nursing assessment or intervention, services that are solely for the convenience of the member, caregiver, custodial care or standby assistance for compliance with treatment, care for others in the household not receiving that group PDN benefit, or any duplicative care covered by another benefit or funding source. So again, with waiver services, they can happen. However, for instance, the DD waiver has a per diem that includes 24/7 CNA level care or lower. So that would include ADLs, things that can be delegated to the CNA. That is included in that per diem for the DD waiver. So I wanted to mention that as being a potential duplication to look for. CNA can overlap with nursing and PDN. However, there must be a medical reason for the two staff at one time for one member. Next slide. So PDN is different than long-term home health. The home health benefits provide skilled services from a licensed certified home health agency, similar to private duty nursing for members of all ages who need intermittent home health services. These services can be at an RN or an LPN level as well, but also include the certified nursing aide and the remote patient monitoring. Intermittent means visits that have a distinct start and distinct stop time and are task-oriented with the goal of meeting a member's specific needs for that visit. So the next slide outlines, it's a chart of the different differences between private duty nursing, intermittent nursing under the long-term home health benefit, along with the certified nursing aide under that long-term home health benefit. I will not read this slide to you, but we will post these slides later for you to review. The next slide also is a crosswalk between the private duty nursing and the intermittent nursing, and outlines the benefits, the summary, type of services, length of visits, any limitations there may be. Again, this will be posted for you to review later. The next slide, again, we wanted to make sure you have lots of examples, but there are examples of tasks for the different categories. Again, this is not an exhaustive list. It does include tasks related to the CNA expanded scope of practice. And there's also consideration of delegation of nursing tasks based on the competency of the CNA staff and with the home health agency policy. I'm going to stop there for any questions or if there's anything in chat that needs to be answered, Paul.
Nothing in the chat right now. You're good to go. If anyone has any questions, you can raise their hand, and there we go. We got a couple.
Okay.
I have a quick question. So you're saying that the maximum is 4 skilled nursing visits daily, correct?
And which slide are you referencing?
I'm sorry, the previous slide where it said 4 skilled nursing visits, maybe one more back. I read it right here. In the intermittent nursing, are brief in nature and up to 4 times a day?
Yes, so 4 times a day. For adults, there is a daily cap amount that members can have to be under.
Okay, and I understand that, but if the feedback from Accenture has been that these cares can be provided via skilled nursing visits, but that would necessitate 8 a day for some of these patients based on their interventions. So I was just wondering if there was any feedback on that.
So depending on the type of services, there are different, the standard nursing visit is up to 2.5 hours, but then there are you can have multiple brief nursing visits, and there's brief 1 and brief 2. There is a home health training, I believe, that Paul had provided earlier, and we can provide those slides, an overview of those slides if you have questions about intermittent nursing specifically.
Okay, that would be great. Thank you.
Mm-hmm. And do we have another raised hand?
That was just Erin. I believe she was commenting on the chat feature. I don't know if it was closed for everyone, but is now up and running. So if anyone has any questions, they can now provide them in the chat.
So sorry about that. Okay, the next slide, slide 18, I believe we're on. Yep, okay. Home health agency requirements. So the home health agency must be a licensed Class A agency by the Colorado Department of Public Health and Environment. They have to be certified as a Medicare home health provider or accredited by a recognized entity such as the Joint Commission. Enrolled as a Health First Colorado provider and in good standing with all of those, with CDPHE, HCPF, and Medicare. And they must follow all those applicable regulatory agency rules and regulations. So there's a lot of rules and regulations for a home health agency to follow. Next slide. Home health agency responsibilities. Again, not an all-inclusive list. The home health agency has a responsibility to inform the family or in-home caregiver of their rights and responsibilities for PDN services and ensure that the environment meets safety requirements and that the physician or allowed practitioner is involved with the PDN care. The home health agency is responsible for meeting all assessment requirements and for ensuring that authorizations are current. This may mean adjusting care plans or prior authorizations as needed by the member's condition. Charting and documentation requirements for PDN services are critical to the provision of care. This ensures that individualized care plan and physician orders are being followed. The home health agency should have oversight of employees to ensure that they are following accepted professional standards of care. Please do not copy and paste charting on visit notes. We've seen a lot of the same thing every day. Even if they're family members being the caregivers, we need to have accurate charting on the visit notes so that we know what is actually happening in the home. Family members or caregivers who meet all relevant requirements can be employed as a member's private duty nurse and may provide services that are identified in the benefit coverage standard as skilled nursing services and that exceed the usual responsibilities of a family member or a caregiver. The family member who is a nurse must meet all the nursing requirements, and they're subject to all the requirements set forth by agency policies and all applicable state and federal laws. Next slide. PDN services are available if the member is unable to perform the healthcare tasks themselves and no unpaid family or in-home caregiver is able or willing to voluntarily perform these tasks. So a family in-home caregiver responsibilities should be guided by age-appropriate expectations to distinguish when a member's needs require care that is beyond the typical caregiving duties due to the skilled nature of the needs or the intensity of the need. So the key to remember here with the family responsibility is the age appropriateness expectations. Diapering of a 6-month-old is an age appropriate expectations. Diapering of a 16-year-old, however, is beyond the normal age expectations. Remember that family is not a staffing backup plan. Staffing cannot rely on family, nor can the family sign away the rights of the home health agency's requirement to follow what is ordered on that plan of care. This family can be used in an emergency, but that should not be your backup staffing for long-term purposes. Protective oversight is not a reimbursable under the PDN benefit if it's the sole reason for the visit and there's no skilled task related. So protective oversight can include, but not limited to, monitoring the member while they're in the home, monitoring ingestion of medications, reminding the member to carry out activities of daily living, facilitating medical appointments, maintaining general awareness of the whereabouts of the member, or guiding the member to assure their health, safety, and well-being. Next slide. PAR procedures. The criteria for approval of PDN service is based solely upon the submission of records that demonstrate the skilled nature of the nursing care needed. And this includes physician or allowed practitioner records, specialty notes, or nursing notes. If it's not documented, it didn't happen. I know that we've heard that, those of us that have been in this field for a while. So making sure that that documentation accurately paints the picture of what is happening for that member. Again, PAR determinations are based on that documentation you provide. It must be current and relevant. Sending 300 pages of notes that do not document the PDN need for the member delays a determination because we have to go through all of those documentations. If the PAR reviewer is asking for specific documentation, it's because they're looking for something in order to approve the skilled nursing tasks. Revisions. If there is a change of condition, please submit a revision within 10 days. If there is a change that a member needs an increase in for an acute period of time, say they had a surgery or an acute exacerbation, please submit that so that we can adequately see what is going on with the member. Likewise, if they are if there's an improvement, which we all hope for, right? Please submit that as well. Reallocation of units has to be done prior to the PAR expiration. So if you have both the RN and LPN in on a case and staffing changes midway through the year, please use that reallocation prior to that PAR expiration. And a change of provider. We recently updated this in June of last year. So I guess it's been almost a year, so not so recent. PAR follows the member. So if you're making no changes, meaning the length of the PAR or the units approved, then that PAR will, if you submit your new 485 and the change of provider form that is completed and signed, then that PAR will follow. But if you are making any changes to the amount of units or to the length of time, then it will go through a medical review. Any questions that we need to answer here?
Yeah, we just have one question in the chat.
I can't see the chat. I'm so sorry.
It's from Deborah. It says, can PDN services be combined with IHSS services through CFC beginning on 7/1/25? That would include homemaker, personal care, or HMA tasks, provided that tasks are not duplicative of PDN tasks.
Yes, and that can happen now as well. So yes, that is something that can happen as long as there's no duplication.
Okay, then we have another one that just came in.
Mhm.
As we were discussing the PAR process, could you please address the following? And there's a couple of these.
Okay.
The provider received a PAR letter from a center stating the following: requests for 10 hours per day for 365 days, approved 0 hours per day for 365 days based on medical necessity, 10 hours per day for 365 days based on program approval. Is this a PAR denial or an approval?
Okay, yep, we'll get to the program approval in just a few slides. You're reading my mind. Is there more questions after that?
That's it for now.
All right. Okay, so next slide is utilization review. The criteria for approval for PDN services, again, is based on that submission of records. I'm sounding like a broken record myself here, but those records need to demonstrate the skilled nature of the nursing care needed. The prior authorization is a request for medically necessary services based on the needs of the member. The presence of additional members in the home does not impact the individual member's medical necessity determination. Combinations of technology and comorbidities are considered when making these medical determinations. It's not based solely on technology, but on the skilled nursing intervention that goes along with that technology. If care overlaps, like I said before, we need documentation that to explain the medical rationale for that overlapping care. Reviews can be standard, rapid, or expedited, depending on the case-by-case situation for members in order to alleviate any undue pain, harm, that type of thing. And incomplete submissions can delay determinations. So please respond to PINs in a timely manner. You have 10 days to submit a request, and as well as the center has 10 business days to review. And if they do ask for a PIN because they're missing information, then that 10 days does start over. So making sure that you're submitting complete information and responding to those requests timely will help speed along the process. The next slide is the appeal options. So there's informal and formal appeals. Informal is the reconsideration or a peer-to-peer physician review, and the formal is the hearing in front of an administrative law judge. So the next slide talks about the informal appeals. So a reconsideration, so if there's a denial or a reduction in services, a home health agency can ask that the PAR be re-reviewed by a different vendor physician. Um, the servicing provider, the home health agency, must request the reconsideration within 10 business days of that initial denial, and additional documentation should be submitted for the reconsideration. It is a suggestion to have additional documentation and very helpful. A peer-to-peer physician review, the ordering physician or allowed practitioner can request a peer-to-peer review with the vendor's reviewing physician to discuss the care and any adverse determination. So that's a denial or reduction. This request again must be within 10 business days of the date of the determination, and the home health agency will facilitate the request at the ordering provider's request or at the approval of the ordering provider. Please do not submit for a peer-to-peer physician review without involving the physician. We want to make sure that we're having a good conversation and that the physician is aware of what is going on. So this needs to be at the direction of the physician. The next slide is a formal appeal. If a member disagrees with the prior authorization decision and you can submit a written request to the Office of Administrative Courts to have the administrative law judge review the determination. A formal hearing date is set and continuation of benefits, if applicable, are applied. Continuation of benefits can only be applied if this is not an initial review. So if you've never had services before, then we cannot continue any benefits. But if you've had services before, they will be continued at the previously approved level. That means that if you've are asking in the PAR for 24 hours and have only ever been approved for 12 hours, your continuation of benefits will be at that 12 hours that had been previously approved. A hearing is held with the administrative law judge, and then that judge will send an initial decision. If there's a disagreement with that decision, then either party can appeal by submitting written exceptions to that. The Office of Appeals will then submit a final agency decision, and at that time, the continuation of benefits expires, and whatever authorized hours are set by that final agency decision would be in place. Now, program approval, if hours were determined to be medically necessary, but there is no change of condition, the department can programmatically reapprove some of those PDN hours, even though the member's condition may no longer qualify for those hours in subsequent PAR reviews. So this is this is an approval of hours based on no change of condition. So the question before is that is an approval for that PAR period, and at the end of that PAR expiration, there will need to be another request. Any questions here?
Okay, real quick, Irina, did that answer your question regarding the 0 versus 10 hours?
Oh, thank you, Paul. Not sure. So what I was trying to understand with that, this is the first time I saw that kind of response, that it was denial based on medical necessity and yet programmatic approval. So there's lots of information in the letter about denial and, all the comments related to medical necessity. So it kind of left a little bit of uncertainty. Is it a true approval still, or is it a denial, and how we manage that, appropriately for the patient?
Right. It is an approval for the member. So the home health agency can provide the hours that are programmatically approved.
Okay. All right. And then, Christine, while I have you, if you don't mind, do you mind maybe elaborating a little bit? Again, we had a offline email communication about that. So if it's an initial PAR situation and the PAR is denied, is the agency and the family decides to appeal, is the agency required to continue services during the appeal process as they are not eligible for continuation of benefits payment? Or how does it impact, like if the agency wants to continue the services, knowing that potentially the PAR maybe, the denial could be overturned? Like how does the agency sort of protect themselves for not having a big chunk of services paid for? You know what I mean?
Right. So for those initial requests, during that appeal, if there have not been any previously approved private duty nursing hours, then there is no continuation of benefits.
Okay. So, go ahead. I'm so sorry.
There are, in the rule, there is under the, I believe it's the utilization management section, there is a statement that says that from the time agencies can be reimbursed from a time of PAR submission until the date of denial, with 30 days or whichever is shorter. So there are some abilities to be reimbursed, but for the appeal process can take some time. I would not be able to tell the agency if this is an initial request that they would be reimbursed for that whole time. So that would be a decision for the home health agency if they are willing to take that on or not. But I cannot say that that would be reimbursed.
And just to make sure that I understand correctly, so if, let's say, for example, there is no appeal in process and the denial was issued, services have been provided, then the agency may potentially be reimbursed up to 30 days of service from the date of denial. However, if the appeal process is involved, that rule does no longer apply and there's potentially loss of reimbursement.
The rule would still apply, but again, not for that whole appeal process.
But for up to 30 days from
Right.
the denial date. Okay.
Right.
And again, I don't mean to be hogging the line, and tell me if we need to talk offline, but
Yep.
what does a center need to submit, or how does the provider in a center kind of communicate that? Because there's sometimes it could be a little disconnect.
Right. Yep. So for the ones that are denied and no appeal in those 30 days, you can submit a request to the home health inbox by submitting the denied ICN numbers and including the PAR number that was denied. And then we do a manual exception process.
Beautiful. Thank you so much, Christine. Really appreciate it. Thank you.
Great question. Paul, got lots of questions?
Okay, we do. Let's just
Okay.
answer just a couple more and then we'll get to the other ones here at the end.
Sure.
Could you quickly just talk about the different requirements or expectations of what a peer-to-peer discussion should involve?
Okay, so for a peer-to-peer, we want to make sure that the physician, the ordering physician, knows that they're going to have this discussion with the physician at Essentra. We've had a lot of physicians we call at a specific time. It's just been placed on their schedule, and they don't have the information in front of them about the member they're going to talk about, or really the details about that denial. So having that physician involved in the peer-to-peer physician review to explain what they're seeing as that primary physician that may not be adequately reflected in the documentation that would require ongoing skilled nursing care. That's what we're wanting, is that physician to be involved in this care, and to have a conversation with the reviewer, the physician reviewer at Essentra, about what they see when that member comes into their office.
Okay, and let's do one more.
Okay.
Is a programmatic approval based on determination of medical necessity?
It is not. It is based on the previous approval, which could have been administrative approval or medical necessity, if there has not been a change of condition. However, the rule has changed, and we want to make sure that that member is not losing any of their rights. So Weaver is a Weaver case law. If those who have been around, it's a big discussion. We want to make sure that we are making those that have no change of condition not lose any benefits. So if there is a change of condition, then we review a medical necessity for approval denial.
Okay, I think we can get to the last two at the end here. So
Okay. All right. So the next slide is a billing overview. Adherence to the guidelines in the Health First Colorado PDN billing manual, along with the general billing manual. So as you can see, they're in units of an hour, based on RN or LPN, or if they're a group provided by RN or LPN. Now that blended rate is available at the request of the home health agency. If you are unsure of the staffing, if you're going to have strictly have an RN or strictly have an LPN and do not want to do that reallocation. So it's based irrespective of whether the service provided by an RN or LPN, you can use that blended rate. The group rate is provided by a single nurse to multiple individuals in a non-institutional group setting. The nurse to member ratio shall not exceed what is required by one licensed nurse to safely care for each member simultaneously. We base that should be based on member acuity and the availability of additional support in the home. Next slide. Some reimbursement guidelines. No more than 24 hours a day for members age 20 and younger, those are pediatrics, and no more than 23 hours per day for members age 21 and older are adults. Services will not be reimbursed if they are duplicate care under another benefit or another funding source. So if it should be, if you have HMA or a DD waiver, and there are services that are responsibility of those that you cannot have PDN as well doing the same care. So billing units are reimbursed in 1 hour units. Staffing is not allowed. Nursing isn't allowed to be sleeping during the scheduled PDN services. Seems pretty obvious, right? And then no individual nurse shall be reimbursed for over 16 hours of care per day, except in documented emergency situations. Another reimbursement condition that I like to mention is in the event of limited nursing resources, a home health agency, for a home health agency, two agencies can coordinate care and provide services to the same member as long as there's no duplication of services on the same date, and each provider obtains a PAR and relates that they are sharing that care. So maybe you have a home health agency that provides the care during the day and another agency that provides the care at night. You would just have to document very clearly in your notes to Accentra who is providing what care and that you're sharing this PAR, and then also have clear care coordination between the two agencies and lines of who's responsible for what. So I do like to mention that if there are staffing issues. The next slide, before we get into some case examples, is the compliance and quality assurance. So regulatory compliance, ensure that all the services providing meet state and federal regulations, and that includes those that are set forth by CDPHE, and that you're following all the conditions of participation set forth by CMS. Like I said before, home health agency requirements have a lot of regulatory with Department of Labor, DORA, all of the things. So making sure that you are abiding by all of those is for regulatory compliance. Quality monitoring. The home health agency is required to participate in regular audits and quality improvement initiatives to enhance that service delivery, and it's also a state licensure requirement, as well as under the federal conditions of participation for home health agencies. Okay, the next couple of slides are scenarios. I don't know if we want to answer questions or if we want to go through scenarios. Let's go through scenarios and then we can do questions. So I want to make sure we get through all of the slides. Okay, so for scenario one, the initial request is 13 hours. It's approved for 13 hours. And the key needs here is ongoing assessment, intervention related to complex medical needs. So member one is a 9-year-old with intractable epilepsy, 11-hour overnight J-tube feedings, BiPAP dependence, and a neurogenic bladder. Member does not tolerate their J-tube feedings well and requires frequent skilled nursing interventions to address the frequent UTI, and sometimes has more than 4 tonic seizures in an hour that do not require any skilled nursing interventions. The agency requested PDN for 13 hours a day. The member was approved for 13 hours to cover the overnight J-tube feeds that are not tolerated and require skilled nursing interventions, and for the continuous overnight respiratory support with the BiPAP. And intermittent catheterizations can also be completed during this time. So the nursing notes for the J-tube demonstrate that the patient does not tolerate the feedings, and that the nurse routinely has to stop the feedings and slow the rate due to the patient's coughing and vomiting of formula. Dietitian progress notes show that they have tried different formulas and feeding rates without success. In regards to the seizures, the neurology progress notes document that they have increased the patient's seizure medications and will follow up with him in 3 months. The logs submitted for the seizures submitted show that the patient seizures are not decreasing in their frequency compared to the previous PAR period, and are not required any skilled intervention. And the BiPAP, due to the patient's increased salivation, they require frequent suctioning during the day and with the BiPAP use when he is sleeping. The next scenario is the initial request was for 18 hours, approved for 10. Again, the key needs ongoing assessment and intervention related to respiratory needs. So member number 2 is a 7-year-old with tracheostomy, G-tube, and dysphagia. The member has a tracheostomy capped while awake. They have 3 daytime bolus G-tube feedings and a 6-hour overnight G-tube feeding, and they tolerate all their G-tube feedings well. At night, their trach is uncapped and they sleep with oxygen and humidified air. The agency requested 18 hours per day, and they were approved for 10 hours for the PDN for the uncapped trach oxygenation needs at overnight. So it's capped during the day, uncapped tracheostomies are outside of the scope of a CNA. There's no documented G-tube feeding intolerances, and a bolus rate does not require titration that would need a nurse. The PDN nurse can perform the overnight G-tube feeding during their 10-hour shift and delegate the bolus feedings to the CNA. So the 10 hours is for that uncapped trach overnight. In the next scenario, the PDN was 49, request was 49 hours a week, none approved. The key here is a stable medical needs and may be eligible for other skilled care needs. So member number 3 is a 4-year-old who was born prematurely at 24 weeks. They eat some food during the day, but have very poor appetite and are underweight. They have 6-hour overnight G-tube feeding that is tolerated well. Until recently, they were also reliant on overnight BiPAP, but it was discontinued 8 months ago by the pulmonologist. They now have orders for as-needed oxygen when sick. Documentation indicates that the last 6 months, they used their oxygen 1 time when they had a mild cold. This member has been receiving overnight services since birth through home health agency for 49 hours a week. And since they have improved and medical documentation no longer demonstrates the need for ongoing assessments and interventions, they are no longer eligible for PDN services. So the need was not identified in the orders or documentation. So over time, the patient's health condition has progressed from an unstable, extremely premature newborn to a stable 4-year-old. That's a positive change in status, which we hope for for everyone. The previous par year medical documentation demonstrated that the patient's nurse had to routinely slow down or stop the G-tube feedings due to gagging or vomiting. And now the patient is able to sleep through the overnight G-tube feeding without coughing, gagging, and it's well tolerated. Previously, the nurse regularly titrated oxygen due to irregular breathing and a hypoxia, and they were placed on that overnight BiPAP, which helped them sleep through the night without any hypoxic episodes, which was also demonstrated in the BiPAP logs. Now, after a recent sleep study about 8 months ago, a BiPAP is no longer needed overnight, and the current patient status has greatly improved from infancy and no longer requires interventions of a skilled nurse. They can be transitioned to a CNA who can be trained to provide the care and through the regular supervision of a registered nurse. Those are our examples. The next slide is a list of resources and support. Just kind of an easy way to find all of the information that we provided. And then again, all these slides will be posted for you, and the links will be available for you. So we can, those are the end of my slides, and we can go to all the questions that I saw.
Okay. Feel free to keep adding your questions to the chat here. We'll try to get them. We have about 10 minutes left. Also, if you have a question, feel free to raise your hand. Real quick, we're going to skip ahead, and Molly, I'll get back to your question. Katie's has a clarifying question in regards to the programmatic approvals. She wants to know, are you saying that hours are being approved without a finding of medical necessity?
For the current, there's a program approval. So there was a previously approved hours. The member no longer meets the rule for medical necessity or under the PDN benefit. However, they have not had that change of condition. So if a member's had previous approvals for years and the rule has been updated, but no change of condition, then we can programmatically approve that time. So for that time period where there's a program approval, that means that there's the member does not meet medical necessity for that par period, but had previously had approval.
Another question here. If a member is receiving continuation of benefits, does a change of condition par submission require relinquishment of the continuation of benefits?
No. If they're actively in the appeal process, that continuation of benefits will remain. That if there's a change of condition and there's a revision and there is additional documentation to support the request, then hopefully we can eliminate an appeal process by having that additional documentation submitted. But the continuation of benefits remains until the final agency decision.
Another one is the PAR step down outlined process in the memo dated April 2023 in place, and a requirement for a reduction of hours over 30%.
So there is step down for applied when there's a reduction more than 30% or a denial for members who have had previously approved hours and are not going with condition or continuation of benefits or an appeal, then the step down is applied, yes.
Okay, then quick follow-up to that. What should home health agencies do if a center does not indicate a step down?
If they believe that there should be a step down, you can reach out to the home health inbox. You can reach out to the provider issues box with the Centra to ask as well. That's usually communicated in the notes with the Trezzo to the provider about step down and if they are qualified or not for the step down. So, but if you have any questions, always reach out to the home health inbox.
I'm going to drop that into the chat right here.
Thank you.
And then one final one, which I don't believe we're going to touch on today, but just so everyone knows, there's a question: are you going to cover the new requirements and expectations of home health agencies regarding the skilled nurse assessor and the acuity assessment?
Not at this time. This is just strictly on the private duty nursing benefit as it exists right now. You can go to the nurse assessor webpage and click on all the links. There's a wealth of information out there. It's updated all the time, almost weekly, and attend all of those trainings and webinars to get your answers there.
All right, that's it for our questions in the chat. If anyone else has any other questions, please put them in there, or you can raise your hand. We have about 6.5, 7 minutes left.
Hi, Deborah.
Hello. I'm not coming off just because I'm not prepared to be on camera, but I'm just going to ask my question really quickly. So if you have a client or a patient that requires continuous intervention or continuous assessment, continuous nursing assessment, and the interventions that might be provided to that patient if they need an intervention happens to be a task that can be performed by a CNA, how should Essentra be looking at that? So basically, I have a patient that has continuous nursing assessment needs, but then if there's an intervention that needs to be performed for them for blood glucose, they might just get a G-tube formula feed, or they might have to get cake gel, and that would be based on a nurse's assessment and judgment about what the symptoms look like and what the blood glucose monitor looks like. But Essentra came back and basically said that the interventions that need to be performed, aren't necessarily being performed often enough to warrant the continuous monitoring, and B, that those interventions could be performed by a CNA, but that's not really true. They're not ordered on a regular basis. They're ordered if the patient needs them. Is that making sense?
Yes. So I can't say to this specific member because I don't have all of the details, but
I guess.
The documentation needs to support that those interventions are happening and that the nurse needs to intervene, and that the assessments are actually occurring. And it's not just protective oversight. If you've gone 3 months and have not had to have a skilled nurse intervene, then that's more like protective oversight. If you're not actually documenting that there's assessments and that the nurse is having to use that clinical judgment to do anything, right? So in this one, because you can't really determine when somebody's going to have a low blood sugar, right? Like that, or need an intervention. So I would have to look at the documentation to see what was submitted, to see if there's any indication that maybe that wasn't happening as frequently as you're stating, and that because Essentra only has those documents to review, so it needs to be clear in that picture. If the nurse hasn't done anything for that whole shift besides just looking at the patient and making sure that they're, you need to show that assessment.
Right. And I feel like we do, and I feel like we do.
Yeah, so we can definitely
POC, but we can just talk offline then.
Absolutely, yeah. If you have
there's a lot of things with this particular patient where the interventions themselves are not highly skilled. However, the interventions are definitely based on nursing judgment and couldn't be done by a CNA because of the scope of practice. And there's some confusion. So I guess just teasing out exactly what verbiage to use so that they can see the picture without saying, without this continuous nursing assessment, the kid could die, right? Like, I don't know how to be more clear than that. Going into details about exactly what it looks like, exactly what the symptoms are, exactly what they're looking for. So, anyway,
if you want to reach out
before we submit.
Absolutely. Yeah.
Okay.
Definitely we can look at this one. Yeah.
We just had one more comment on the chat. Could you just really quick tell people what can be submitted to the home health inbox. This one's like, hey, if they had a PAR denial for PDN services, if they want to request a reimbursement, what kind of things can people send to the home health inbox regarding PDN denials?
Really any of the questions, honestly. So if you have like a technical question about submitting documentation or having issues with a Trezzo, that goes to the Colorado provider issues at Essentra.com, which I believe Paul put in there in the chat. If you're having questions about, notes that are put in there, that Essentra can answer those directly. But if you have questions about policy or program, any issues, you can send over to the home health inbox, and if we're not the ones to answer it, we can find those the people that are that can help you with those questions. I hope that answered what you. Okay. All right, we have about 2 minutes left, so I am going to end unless we have any other questions. All right, thank you all for taking time. Again, this will be posted on the PDN webpage, the slides and the recording of the training. All right, thank you all.